And I
Thank you,
will
Jeffrey.
introduce our next speaker, who really requires no introduction, Dr. Heather Gornik, who we've been together on this almost from the beginning. We're very close friends and very close colleagues, and sometimes I think she's my little sister. She doesn't let me get away with anything. Anyway, there aren't many people in the world who know more about FMD than Dr. Gornik does, and she's going to update us on the registry. Heather is now at University Hospital, the Harrington Heart and Vascular Institute in Cleveland, Ohio. Heather?
Hi, Jeff. Good morning. Hi, everybody. I'm so pleased to be with you today. I wish we were in person, but it's terrific for us to have such a global reach today. Are you able to share my slides? Great. Give me one moment. How's that, Jeff?
Yeah, good.
We're good? Okay. All right. Well, it is my absolute pleasure to have a chance to provide an update on the U.S. registry today. The title is, We Have Come Far, We Have Far to Go. So just for many of you know all about the United States Registry for FMD, but for those who are perhaps new to it, let me just take a moment to talk about the organization. The registry is sponsored by this wonderful organization, the FMD Society of America. We could not do this registry without the FMDSA's financial as well as other support. It's coordinated by the University of Michigan Cardiovascular Outcomes Research and Reporting Program, that's called MCORE. And the organizational structure includes a steering committee and publications committee. And Dr. Olin is chairman of our steering committee. We started enrollment in January 2009 at 7 clinical centers, and we currently have 16 and soon to be 17 active and enrolling centers across the United States. Each center has approval by the Institutional Review Board or Ethics Committee at their center, and each center has an agreement with the coordinating center, MCORE. And some center processes require informed consent, where patients provide informed consent to participate. Others that don't enroll patients prospectively when they come into the clinic may not. They may do it by chart review, but most require informed consent. And we also have a process for enrolling children in the registry at some of the centers. I want to pause here just to acknowledge the amazing team of people who are involved in the U.S. registry. Usually we get together at the FMDSA meeting. I hope we're all together next year. Of course, on the FMDSA side, we have Pam Mace leading the effort. She sits on our steering committee, as well as many other FMDSA volunteers and donors. We have the MCORP group, which is the effort is led by Jim Freilich, Eva Klein-Rogers, our statistician Xiaoqi Gu, Patsy Brunger, and Rachel Krallman, and Dr. Eagle, who leads MCORE. And then we have our wonderful site investigators, and they are listed here, and these are the principal investigators at each site. I just want to take a moment to mention that the investigators provide their effort without any compensation. This is all voluntary. This is a labor of love. There's no funds that go to the individual sites or investigators for participating in the registry. And these are all the enrolling clinical centers across the United States. You can see here, we now have 16 and soon to be 17 clinical centers enrolled. And I want to mention a few new centers that came in online within the past year or so. Those include Seattle Children's, just pediatrics only, of course, the University of Colorado, and North Shore in Evanston, Illinois, near Chicago. This is what we fill out for each patient who enrolls in the registry. And again, this is where we really see that labor of love. This is pretty, as Dr. Olin knows, labor and time intensive. Each patient in the registry center is identified by a unique ID number, so we do not put names on the registry form. And then we complete this detailed standardized data collection form for every patient upon initial enrollment and for each follow-up visit. And we have definitions for all of these little fields with the check boxes. And data is ultimately entered at the centers into an online password-protected database called the stringofbeads.org that Xiaoqi Gu manages. On the baseline data form, we collect information on demographics, presenting symptoms, medical and family history, medications, physical exam, imaging studies, vascular procedures, some laboratory tests, genetic tests, pathology if available, and vascular and clinical events. And we collect similar information on the follow-up form, including whether there have been any events since the prior visit. Our data is maintained at MCorp in a secured fashion, and Xiaoqi Gu monitors the data quality. We have a protocol for handling multi-center enrollment. Some of our patients are actually seen at multiple sites in the US registry. And we've recently developed a process for adjudicating new vascular events that may occur in follow-up. So if a patient were to have, and it's unusual, but it does occasionally happen, a new event, a new dissection, we have ability to request medical records from the centers, and then we have a event committee that in blinded fashion kind of reviews the event and confirms that it qualifies. I want to mention a new initiative that we took on over the past year. I think we were inspired by Dr. Pursue and our European colleagues, and that is for image capture. So investigators are now asked to submit up to 2 angiographic images. It could be a catheter angiogram, CTA, or MRA that best confirm the diagnosis of string of beads, multifocal, or focal FMD at any location in the body. And these images are usually captured by the investigators with a snipping tool, and no patient identifiers are on these images, and they're uploaded to the secure stringofbeads.org website. And with Dr. Olin's leadership and Dr. Freilich and others, our steering committee is now in the process of determining how we're going to adjudicate these images to confirm the FMD diagnosis. And this will be for patients new to the registry and ultimately all the patients previously enrolled. Briefly want to touch on our accomplishments. I think we've had a great run over these 10 plus years. I think the US registry has helped advance understanding of FMD and awareness of the disease in the medical community. And we've had 10 published papers and over 24 abstracts at national meetings. Most importantly, I think the registry data has directly informed management of patients at our centers. And I know for Dr. Olin and myself, we tell patients that a lot of things we can tell them today is because of information we've actually learned from the registry. And my favorite part is we've had a chance to engage a lot of young people, the next generation of FMD clinicians and researchers in the registry. As Dr. Olin mentioned, this was the paper that started it all. This was the first publication in 2012 in the journal Circulation in 447 patients. And we now have about 10 papers published in the registry and hopefully more to come. I want to just go over our registry enrollment. The registry continues to be very busy and productive. I think we're on tap for about 350 enrollees in 2021. And as of a few days ago, there are now 3,359 patients enrolled in the US registry for FMD. So I think it's fair to say this is the largest cohort of patients with FMD. And we do have good follow-up data for about 78% of patients who've been in the registry for at least a year have a follow-up visit recorded in the registry, which is going to be very helpful when we do our natural history work. Briefly, just want to go over a few of the lessons we've learned from the US registry over time. Dr. Olin mentioned a number of these. I think we really learned that the symptoms of FMD go far beyond the traditional high blood pressure, and that includes headaches, the pulsatile tinnitus, neck pain, and dizziness. And actually, over a quarter of headache sufferers have daily headaches. So this is really a major morbidity in our patients with FMD. We've learned cerebrovascular FMD is as common as renal FMD, and also that the majority of patients with FMD, this has been shown by our European colleagues as well, have involvement of multiple areas of the body. We've also learned, as you've heard, that FMD can, in some patients, be an aggressive vascular disease. 1 in 4 patients have had a dissection. 1 in 5 patients have an aneurysm. And as you heard from Dr. Olin, about 40% of patients, this number may now be slightly higher, with FMD have either a dissection or an aneurysm. And some work by Dr. Freilich and medical student Lather at the time, about 13% of women with FMD who are imaged have a brain aneurysm, and among those, half have multiple brain aneurysms. We've also learned that men are the minority of patients with FMD, but are twice as likely to have dissection or an aneurysm than women with FMD. That was Esther Kim, led that effort a number of years ago. And it's interesting, the pattern of disease in men is different than women, more likely to see renal involvement in men and cerebrovascular involvement somewhat less common. We've also learned that patients with FMD who are diagnosed at an older age, 65 plus, tend to have a milder phenotype with lower rates of dissection or other vascular events and procedures. We've learned that smoking is associated with worse outcomes, including major vascular events, aneurysms, and procedures among patients with FMD. So anyone out there who's a patient who continues to smoke, I think more official data-driven reason to quit. And pediatric FMD, we've learned, has different clinical features and pattern of vascular bed involvement than adult FMD, and renal and mesenteric involvement much more common than cerebrovascular in children. Just want to share a few things that came out of the registry in the past few months. This is a manuscript that was led by Ido Weinberg and Andrew Dix at Mass General from the registry, reporting on that symptom we've talked about today of pulsatile tinnitus among our patients. And I just want to give a shout out to Pam Mace, because at some of the initial meetings in 2008 where we were discussing the registry fields, Pam really advocated to include the pulsatile tinnitus variable as a presenting symptom, because she personally had experienced it and just heard from so many of you patients how common it was and wanted to officially study it. So in this analysis, we found that 37% of patients in the registry have the swoosh. We're also capturing non-pulsatile tinnitus as well, which we don't think is related to FMD, but 37% have the swoosh. And the swooshing is associated, as you'd expect, with carotid or vertebral FMD, headache, also neck pain, dizziness, and a clinician hearing a bruit on exam. Really importantly, this analysis showed that the presence of pulsatile tinnitus is not associated with stroke. Okay, so this highlights the importance of this symptom as being very annoying, but not life-threatening. And we may talk more about this later, but a great resource for anybody who has pulsatile tinnitus is the website whooshers.com. I also want to briefly mention some new data just presented last month by Kajal Shah and Aditya Sharma from the University of Virginia on racial differences in FMD. This was at the American Heart Association. And this was a report on 1,897 women who had multifocal string of beads type FMD in the registry. Almost 90% were white, 6.5% were Black, and we had lower representation of Hispanic and other races. In this analysis, it was seen that the age at diagnosis and first symptom were similar between white and Black patients with FMD, but there were some differences in presentation. Black patients were more likely to have had a history of hypertension, stroke, and a subarachnoid hemorrhage, a kind of head bleeding, and less likely to have had a dissection than white patients. There were also some different racial differences between Black and white patients in vascular bed involvement, though not all patients had comprehensive imaging. So this really highlights the need for further research to understand racial differences in FMD, and also the need for us as a registry, and we're very committed to this as a steering committee, to diversify the population of patients in our registry. Our current and future initiatives, things we're working on as a steering committee, we're selectively expanding our enrolling centers to increase patient access to the registry across the United States. We don't quite have the global expanse of the European International Registry, but we really want to try to cover the United States. We're also working on racial and ethnic diversity. We have an ongoing focus on data completeness and quality. We've done some recent data form updates to capture some of the new treatments for headache therapy and also to expand the ability to capture genetic testing. And as you heard, we're working really hard on the diagnostic imaging capture and the adjudication. Over the next year, we'll be working on some analyses and manuscripts related to the follow-up events and natural history. Dr. Olin is leading an effort to look at our 10-year experience and any changes in our registry population from that first 447 to the 3,000 plus we have now. And we have other investigators looking at reasons for delay in diagnosis, the racial differences, as you heard, and also Dr. Kim and Dr. Weinberg involved in a project looking at SCAD and FMD. So on behalf of the steering committee of the United States Registry for FMD and all of our investigators, we've come pretty far. We've got a long way to go. We look forward to doing this. This was happier times, Jeff and Pam, as you'll remember, right before the pandemic, we were meeting to adjudicate events, and hopefully we'll all be all together soon. And above all else, we all want to thank the patients enrolled in the U.S. Registry for FMD and also the FMDSA. Any accomplishments we've had are because of you all. Here we are. This was in Poland, raising a glass to all of you. You'll see many of the speakers today, and Dr. Freilich, who runs the MCOR and the coordinating center for the registry. And again, the U.S. Registry for FMD would be nowhere without the support of the FMDSA. So again, we thank you so very much.
Wow, Heather, during the time, you got so many questions that as I'm reading one question, three more are pouring in.
Oh
It was
boy.
really hard to keep up with. Let me just consolidate a few questions. A number of individuals asked, like, number one, how do they get to participate in the registry? And how do they go about finding a center where someone has expertise in FMD?
All right. Well, in terms of the United States Registry, in order to participate, you need to be seen at one of our 17 enrolling centers. The FMDSA has a wonderful page on its new website, which I think just launched yesterday. It's beautiful, by the way, where you can see the listing of all the centers and even links to the emails, email information and the websites for the sites. You have to be seen at one of those centers because we really want to make sure we're enrolling patients who have FMD who meet the criteria. As you heard from Dr. Olin, there's a lot of overlap with other conditions. So it's very important you're seen at one of the centers. And what was the other question?
How do you go about finding an expert in FMD if you're not near a center?
I would say, in terms of FMD expertise, I think you can't go wrong with being seen at one of the registry centers, because again, these are folks who are voluntarily dedicating their time to study this condition, seeing patients with FMD, participating in our registry and our meetings. So I strongly recommend those clinical centers. Again, FMDSA website.
Here's a patient who had a coronary dissection who has multifocal FMD and a 4+ millimeter basilar tip aneurysm in the brain. Is the aneurysm more likely to rupture during surgery because of FMD, more likely to rupture because of FMD if I decide to have surgery?
Okay, these are good questions. We don't have data on whether patients with FMD with aneurysms are at higher risk of rupture at a given location than patients without FMD. However, I think basilar artery aneurysm is something we do worry about that location for all patients in terms of rupture potential. And it sounds like this patient's under the care of an excellent neurosurgeon or neurointerventionalist. In my experience, it doesn't seem like patients with FMD are at increased risk of complications with vascular procedures like other things like Ehlers-Danlos, where we worry about the procedures. So I don't think that necessarily puts a patient with FMD at higher risk for a repair.
I agree completely with you. Someone asked a question about, are patients being missed by not being included in the registry? And this particular patient was seen at one of the registry sites, but not put in the registry. Any advice for that?
Yeah, I mean, I think you as a patient, if you're seen at one of the registry centers, I know a lot of times patients come to see me, and I know you, Jeff, too, because they specifically want to get in the registry. So you can always, you ask, am I going into the registry? Why am I not being consented for the registry? I think there's some times where patients have this FMD-like condition that, Jeff, you went over so beautifully, where they're a woman with dissections and tortuosity, but they don't meet the formal criteria of multifocal FMD to put in the registry. And right now, we are not enrolling those patients in the FMD registry. And those may be the folks who aren't getting into the research. So I think, as always, ask your doctor if you qualify for the research, and if not, why.
One of the things that I am constantly amazed by is it's not the doctors who are driving this, it's you all, the patients. And I always ask someone who comes to see me how they found out about this, and it's through the research that they have done. And I think all of these studies related to race and ethnicity and things like that are greatly tied in with level of education, ability to travel to registry sites, etc. Because this, from my perspective, has been a patient-driven referral pattern and not a physician-driven referral pattern for most instances. Not all, but most.
Completely agree.
When a patient in the registry and changes providers, how does the registry data follow them appropriately?
Yeah, that's great question. And we have worked out a process, because there are patients who've seen both Dr. Olin and myself over the years, or people change institutions. And usually what it entails is you're actually consented to participate in the research at both centers. So if a patient had seen someone else and then comes to see me and knows they were already in the registry, we consent them at our center. And after that consent, there is a process that Zhao Gu at MCOR helped us develop, where we actually can match the patient, usually by the date of birth and some other information in the registry, to the current person now seen at the new place, and we sort of merge the records. So we have a process in place, but you do need to be seen at another center officially and enrolled in the registry. Your registry information wouldn't automatically transfer.
Yeah, and that ties into the next question. Is there a way for the patient to add their medical information to the registry? And as Dr. Gornik said, there really is not. I know there are virtual registries. For example, at Mayo Clinic, they have one for SCAD, but we do not have a virtual registry, because basically we have to make sure that you have FMD to put you in the registry. Otherwise, it will confound a lot of the data that we see. And from the person from Canada who asked that question, yeah, we want to get Canada involved in this. We want some sites in Canada, and we're actively looking for them. So if you know of any sites, let us know, and we'd be anxious to follow up.
We put out a few feelers. We'd love to become the North American Registry, because I think, Alexander, I'm sure you're backstage. If we don't, I think the international efforts may take Canada, but we would love to become the North American Registry.
Yeah, Alexander, we're telling you right now, you cannot cross the Atlantic, okay?
Canada, we're fighting over you.
How do you differentiate FMD neck pain from that of cervical spine symptoms?
I would say hold that question to this afternoon, because this will come up. Marianne Corey, a medical student, is going to give a presentation related to that topic. So can we hold that question, Jeff?
Yeah, sure. This was a person, I don't even know the answer to this. This person was in the Mayo Clinic registry for FMD several years ago, but Mayo's now not part of the registry anymore. Are the records still part of the registry study? Do you know the answer to that?
The data still, everything is done in accordance with the data use agreements for the particular site. I'm not sure of the specifics there. I know there have been a few sites that have closed over time, usually due to low enrollment or changes in personnel. And for many of the analyses, those data are still in the registry.
Oh, I saw your comment after that, Heather. Sorry.
Little sis is
how do you apply to be at one of the centers? You don't have to apply. All you have to do is decide what center you want to go to, call for an appointment.
I wonder, Jeff, they may be asking if they're a center, if maybe a physician who's asking if they want to be a center. Is that the question?
Good point. I don't know. How do you apply to be seen at one of the centers?
Oh, to be seen. Okay.
So, yeah. And if you still have a problem, just email Pam May. She only gets about 1,000 emails a day. So she'd love to have a few more from you. How are we doing on time here? We have a couple more minutes.
Can I ask there was a can I ask a question? One of the comments I saw, Jeff, if I could, I thought it was a good question. They were seen at the registry. They hadn't been seen at that registry center for many years, but something happened. They had an aneurysm or they had an event. Is that captured? And I think every center works it a little differently. Some have a way to do like capturing events if they're not seeing you. I know at my center, just because we see so many patients, we usually capture things that happen when we see you next. I don't know how you do that, Jeff. Do you need to see someone to capture an event?
Yeah, usually. If someone called and said that the circumstances have changed and they can no longer come and see us, but they're in the registry, we would let them send the records and we would evaluate them and update the records. But the 99% come and are seen in person. Okay, I think we will stop for lunch. It is 11:08. Lunch is from 11:10, so make sure you don't start eating for 2 more minutes yet, to 11:40. And when we come back at 11:40, Dr. Gornik is going to moderate, and we'll start the second half of this virtual meeting. Thank you all for attending.
Dr. Olin, always a pleasure.
Bye.